Hello, good evening. All right. So that's the official disclaimer that all these images will be for medical training purpose only, and it is for mature audience. Okay, welcome to session 29, and this is about male reproductive organs. Now, what we'll do is say there are several things about say male reproductive organs, but our main focus today will be on prostate, right? So as such, we shall be covering all others, but they will be in bit brief. Means all the necessary information will be covered, but prostate would be the main focus. Okay, one important thing. Tomorrow, can we start at say 7 o'clock? Because topic is bit lengthy. It is rectum and anal canal, and there are so many clinical things associated with it. So can we start at 7 o'clock instead of 7:30? That is for tomorrow, right? At 7 p.m. instead of 7:30, half an hour early. Can we? Right, just let me know. All right. So for male reproductive system, see, we can divide it into two parts. Great, great. All right. Sure. We'll start at 7. Thank you. The external and internal. Right. In external, it is penis and the scrotum, right? In scrotum, there was testis and epididymis. Epididymis, right? So we have already talked about penis, we have talked about scrotum, in that testis and epididymis. So this would be our today's focus. Plexuses, that would be our last session. Say today we are doing this, tomorrow rectum and anal canal, and then the last session that would be about all the plexuses, right? Again, it would be a lengthy session, so I might ask you to meet at 6:30, right? But we'll decide for that tomorrow. Okay, but yes, that would be the session in which we'll be talking about the pelvic walls, all the plexuses, etc. So that's why today I'll be taking part of it today, just to give you the brief of it during the innervation of prostate, right? So that will give you a reasonably good idea. But day after tomorrow, when we'll be taking all the plexuses, it will be crystal clear, right? Okay. So regarding this internal, these are the topics, right? That would be the vas deferens. From vas deferens, right, they go all the way, and there they meet seminal vesicle, and then both of them they unite to form the ejaculatory duct, correct? And then comes the contribution of prostate, and that's how the entire process is completed, right? So these will be the topics of our today's discussion, right? So let's start with the first one. So this is just a brief idea about, right, what exactly the vas deferens is, also called as the ductus deferens, right? They both mean the same, so I'll just write ductus deferens. Okay. So the production, sperm production, that is over here, right? So it is the testis which gives for sperm production, right? Under the influence of testosterone. Now what happens that these sperms, they are immature, right? They are immature sperms. All of them via vas efferentia, they all reach to the second organ, and that is epididymis, right? Which we have talked about. So that's the epididymis. It is the epididymis where there would be the storage, correct? Plus the maturation. Plus the maturation. That's the reason that in semen test, if you remember, what they do, they go for the sperm count, they go for the sperm maturity, and they go for sperm motility. So whenever you see any of this semen report, you need to see all these three factors, because all these three factors, they are needed for a proper sperm, right? Okay, so now comes our today's topic. That's the ductus deferens. It means from this epididymis, that's the tail of epididymis, and the journey starts. All the way it goes into this form of ductus deferens or the vas deferens. So these mature sperms, they are taken from epididymis to their final destination of ejaculatory duct, right? Okay. By the way, right, when we write testis, if you write it like this, right? So it is, the spelling is Testis. This means this is singular, right? Just to remember, right? And otherwise, when we write like this, so that means it is plural, right? More than one. Okay. So now, what would be the exact journey and the location of this vas deferens or the ductus deferens? Well, it starts from scrotum, right? In scrotum, the posterior border, right? Posterior border of testis, right? Because we are talking about one vas deferens. It is a paired product. Okay. From there, now we know that testes descend, right? So they go all the way from deep inguinal ring to inguinal canal to superficial inguinal ring, and then they land into the scrotum. So they carry all the structures along with them. So that's why this would be like a reverse journey, right? So here it is. This is superficial. This is superficial inguinal ring, right? From there, that goes the famous inguinal canal. From inguinal canal, there would be the deep inguinal ring, correct? Now, from deep inguinal ring, there it goes. Now, over here, it would meet inferior epigastric artery, right? Inferior epigastric artery. Inferior epigastric artery is on the medial side, right? So this vas deferens smartly takes a turn, right, from the lateral aspect, enters into greater pelvis. Now we are well comfortable with that greater pelvis is actually a false pelvis, right? But it just enters into that area, right? And then such a long journey, right? See, still it's not over, right? And there it comes in contact with, right, all those, it crosses and it tells hi to obturator nerve and vessels, right? And then it enters into true pelvis, true pelvis, right? Or the lesser pelvis, greater pelvis or the lesser pelvis, right? Lesser pelvis. And then it meets over there seminal vesicle, right? Seminal vesicle. Again, seminal vesicle is on the medial side. So this enters onto the from the lateral side. And then the opposite side is also coming, right? Both of them, they travel all the way to the base of prostate, right? At the base of the prostate, it joins seminal vesicle, right? So over there, it joins seminal vesicle. Now, this area is slightly bulged, right? So that is what is called as the ampulla. Ampulla. And now this joint effort has formed what's called as the ejaculatory duct. Well, ejaculatory duct from both the sides, and finally they enter into the posterior wall of urethra. Actually, we should be more specific, prostatic urethra, right? And over there, there would be the glands, they will also be entering into it, and thus the entire journey would be complete. So this is the journey, all with all the salient features of the vas deferens, right? Okay, let's see that. Here it is. See, things which we already know. Urinary bladder, right? That is there. And there would be the urethra. This is rectum. So this gives the reference that this is anterior, and that's posterior, right? And all these references, they are like, see, it crosses inferior epigastric artery. During catheterization? No. Actually, okay, let me take, say it happens like during catheterization, what really happens is, say this is urethra, right? So during catheterization, yes, that catheter would actually be crossing because it goes straight away into the urinary bladder, right? So those ejaculatory ducts, they are outside. Their openings, they just open into the posterior wall of urethra, right? See, just hang on for this question for about a minute. I think there is okay, okay. I'll draw that figure, right? It is not there. I'll draw that figure. Just hang on. Okay, so right, inferior epigastric artery, and there I said that here it meets that, yes, seminal vesicle. It says hi to that, and this dilated part, it is what is called as the ampulla, right? And then it meets seminal vesicle, and they lead to form that ejaculatory duct. Same thing happens on the opposite side, and they open into the urethra, right? Now the question is regarding catheterization, what really happens? Will it pass through ejaculatory duct? No, right? See, ejaculatory duct is like it is opening, right? To be precise, I should draw it something like this. It opens here. It opens here, right? So if I take a cross section, it would be like this is the entire lumen of the urethra, right? And all those ducts, they are opening into those walls, into that lumen, right? So they are ducts outside, right? But over here, so they just open into that, right? And this catheter would be brushing past these opening, right? Because it has to reach all the way to the bladder, because this would be the prostate, right? So it has to reach to the bladder, so it would be actually brushing past the openings of the ejaculatory duct, right? Okay, So that's how, say, they will be located, right? So here our main purpose was to talk about ampulla, ejaculatory duct, and this important inferior epigastric artery. But rest is all coming up. Okay, see here. This is also, or say we can do this. This would be the path of catheterization, catheter. This would be the path of catheter. Now you got it? So that's the ejaculatory duct. This is just the opening, right? It is like that ejaculatory duct would watch the catheter passing in front of him, right? So that's the prostate. That's the prostate, right? And that's the ejaculatory duct. This one would be the seminal vesicle, and that's the urethra. This is the perineal body, right? Perineal membrane. And over here, that would be the membranous urethra and the penile urethra. That's the part, say, right? And we have got pre-prostatic part, prostatic part, then there would be the membranous urethra, there would be penile urethra, that is the bulbous urethra, right? This would be the bulbous urethra. So that's how, say, these are arranged. Obviously, this is anterior, and that's posterior, right? This side. Two things which we see. One, that's the bladder. Yes, we know that. Pubic symphysis, very perfect, right? Perineal membrane, good. Perineal body is good. Urethra, we talked about. And that's the ejaculatory duct. That's the area of focus for today. And this is median umbilical ligament, right? You know about it. And that's the peritoneum, rectovesical pouch, rectum and vesicle. So this is rectum, that's the urinary bladder, that is vesicle, this is rectovesical pouch, right? All those things. Okay. Now, see, we said that there is ampulla, right? Ampulla of vas deferens. Then seminal vesicle, right? Seminal vesicle. They both form that ejaculatory duct. And this ejaculatory duct, that would be formed on both the sides, right? But in seminal vesicle, we would add one extra thing over here. This is what is called as the excretory duct. Excretory duct. So seminal vesicle, finally, all those vesicles, right? Finally, they lead to form a one single duct, right? And that is what it will meet to form the ejaculatory duct. From the right side, from the left side, right? Because this is a paired structure, right? And they open in what's called as the prostatic urethra, right? The part of urethra which is into the prostate, right? And important, the posterior wall, right? Somewhere in the midway, right? So that's how the system is arranged. Now regarding the arterial supply, nearest supplies, right? Nearest supply. So nearest is what? Urinary bladder, right? Urinary bladder. And then there is superior vesicle artery. Its terminal branch, last branch, that goes, and that is artery to ductus deferens, right? This is artery to ductus deferens. One important thing that this will go in anastomose with testicular artery, right? Testicular artery. Regarding the venous plexus, things are much easier. You will find one common pattern. That is, all of them, they are very fond of forming the plexuses, right? Regarding the venous drainage, right? I wrote plexus, but yeah, there are plexus. Let me clarify. This is about, we are talking about now venous drainage. This is in green color, right? So all the veins, right? All the veins from ductus deferens, right? They lead to vesicle venous plexus, right? And all these venous plexus, they will be going for internal iliac vein. Right. That's how it goes. So this is what really happens in vasectomy. This is a male sterilization process, right? The way in female it was tubal ligation, same way over here it is like vasectomy. Now, why it is done at this junction, right? Why the ductus deferens is cut? So many areas, so many things, anywhere it could have been done. But why over here? Because this is one reversible. It is reversible. After performing surgery and after few years, right? If the guy changes his mind, so then there is a possibility of reverse of this operation. This is what is called as the recanalization, right? No doubt it has got some complications, right? Because by the time tissues, fibros, this, that, so many things. But yes, it is possible, right? That is what is done, I call as recanalization. And this is done under LA, local anesthesia. Right? Vasectomy is done under local anesthesia. Now, in this, the advantage would be that there would be no difference in the sexual life of that person, because see, testosterones, they will be produced normally, right? So testosterones, they are produced, right? And they will be drained in veins, right? They will be drained in veins from the testis. So that means testosterone level will remain high. But those sperms, they were traveling via vas deferens. So that vas deferens, that has been blocked. So thus the purpose is served, right? So that's the purpose how it's really done. Let's move on to the second topic, and that is seminal vesicle. Now, this seminal vesicle is actually so important, as we said, that that's where the maturation will occur, right? Those sperms will mature. So this is the reason it would play a very major role. Now, these are like two lobulated sacs, right? These are two lobulated sacs, and we know where it is. It was on the posterior aspect of the bladder, correct? Because when the vas deferens was coming, right, vas deferens came on the posterior side, it said hello to seminal vesicle and told that just meet after some time. So seminal vesicle also said, okay, I'll start preparing my excretory duct. It is that excretory duct, right, which meets the vas deferens, both of them joint effort, ejaculatory duct, and finally they land onto the posterior wall of urethra, right, where the opposite side also comes and they also join. So that's how it forms. So when we are talking about seminal vesicle, it is posteriorly situated, posteriorly to bladder. So it would obviously be between bladder and posteriorly there is only one structure, and that is rectum. Correct? So it is lobulated structure which is between bladder and rectum. Yes, we remember one more structure, and that is, we just said that just before joining the excretory duct of seminal vesicle, that's called as the ampulla, right? Do remember that, and then that's what is ejaculatory duct, right? Now seminal vesicle is important for one very striking reason. The secretion of seminal vesicle is forming almost 60%, even more than that, right? I should write more than 60%, 60 to 70% of seminal fluid. So that's the major contribution of it. Now, what it is really doing, there is fructose, right? In that it is adding fructose. So, which will be playing a vital role in the nourishment. Plus, this fluid is alkaline. This fluid is alkaline. Because in female tract, it is all acidic. So that's why this is necessary to create an alkaline system so that it gets neutralized over there, right? So that's how it really goes. So when we say about seminal vesicle functions, right, we just put one, and that is the storage. But I'm sorry, not the storage. It gives the seminal fluid, right? Seminal fluid. Second, it helps for the stability of sperm and the nutrition. Major nutrition that would be provided by the prostate, right? Yes, that's right. That's right. Okay, right? So this is what really happens. Now, one more important thing, that it is very much necessary, as we said, the motility, right? The sperm motility. That sperm motility, that is also the function handled by seminal vesicle. Plus, for fertility, it is necessary that irrespective of how much that female is say ready for the fertilization, but her system is not ready, right? There is something like female immune system. That immune system would find that who are these sperms, right? Who are they? They are like foreign bodies, and it would immediately attack. So it is this seminal fluid, right? It is the seminal vesicle secretion that would come into picture, and it would suppress female immune system, right? That immune activity in the system, right? So that at least few of the sperms, they successfully reach to the destination for the fertilization. So that's the reason that this entire game is where seminal vesicle is vital, right? Because it gives that large amount of fluid. At the same time, it gives that stability of sperm, right? Nutrition, plus the prostate also provides nutrition so that they travel successfully. All of thus it creates the environment for sperm motility. And finally, in spite of that loving female, right, but her track is not knowing that no, all these sperms, they are good, right, she will attack, and many of them, they will be sacrificed. But because of this seminal vesicle, few of the sperms, they will survive and they will go further. The next topic, that's the main topic for today, and that is prostate. That's the main topic. This is the largest accessory gland of male reproductive system. Largest. This is exocrine, right? So when we say exocrine, exocrine glands means they will be secreting their secretions into ducts, into duct or ducts, correct? Because when we talk about endocrine, that means they would do what? They would secrete their secretions into the blood, right? They will secrete into the blood. So that's where we say them as endocrine. These are exocrine. So they will be secreting into duct. That's right. That comes the chief guest of it. Yes, yes, yes. That's right. During criminal examination, yes, it is done. That's right. Right. So here comes the chief guest. Right. So that's the chief guest, guest of honor. Right. And this is the largest accessory gland. Now, when we say about the exocrine glands, as we said, that it would be releasing into duct or ducts and into the posterior wall, right? But say in prostate, prostate believes in that these are like 30 to 50 gangsters, right, into the prostate. They do all that work, right? Prostate is just like a chief guest. There are 30 to 50 those tubular glands, or we can say tubulo-alveolar glands. So they do all the work, right? And finally they report to the prostate that yes, it's all ready, right? And there is the duct, and they say that let's open it into the urethra, right? So it means that that's the urethra, that's the prostate, and they will be, say, those ejaculatory ducts, they were coming, right? They were coming, they were opening, and similarly, prostatic duct, that would also open into it, right? Into the center part. So here it is. Now this will give the complete picture. Complete picture. Here it is. So first thing first, what it is, here it is, right? That's the prostate. And the muscles which are already known to us, levator ani, we know that. Urinary bladder, that is pretty good. That's the trigone, right? Ureter opening into the trigone, yes, that's good, right? And the urethra starts. And in case of male, there is proximal urethral sphincter and the distal urethral sphincter, right? So here is the proximal urethral sphincter. This is the proximal urethral sphincter. Now, because we are discussing prostate, so that's why proximal urethral sphincter will do one thing, and that is all those secretions, right? All the way they were made in testes, all the sperms, all the way they reach over here. And how stupid would it be that if those sperms, instead of going in this direction, they start going up and they land into unknown territory of urinary bladder. Now that would be pathetic, right? So there comes the proximal urethral sphincter, right? He tells no entry, right, to those sperms. So that's what it does, right? How interesting. Okay, now see, proximal urethral sphincter, that's fine, it really does. But there is one more sphincter, and that is distal urethral sphincter, correct? So actually, the prostate is lying between these two sphincters, right? That is between these two sphincters. From there starts the membranous urethra and then the perineal membrane, and all good. We write it over here, right? Say this prostate, if you really want to compare, so that would be like in case of female, it is para urethral gland, and there is a name of skin, the way you want to pronounce skin or skinny. So seminal vesicle, right? Then the prostate, and then there was bulbo urethral glands. It is the joint operation of all of them. That's where the seminal fluid is formed. Seminal vesicle, as we said, it is about 60 to 70%, right? Prostate, it is about 25 to 30%. But some contribution is from these bulbourethral glands also, right? So let's put it 10%. All of them, they vary by 2 to 5%. So in some books, something is written. So there will be, but this is like in a gross way. Those bulbourethral glands, here they are. So they are bulbourethral glands. So that's where they open, right? So that's where the contribution of the third candidate. You see, this was bladder, correct? And then we drew the prostate over here. That would be called as the base. This would be called as the base, right? Then there would be anterior surface and the posterior surface and the inferolateral surface. This is quite similar to the bladder was arranged like that, correct? There were inferolateral surface, anterior surface. So same way over here, that's the anterior surface. On the back side, there would be posterior surface, and then on both the sides, there would be inferolateral surface, right? So it is that way, it is pretty easy, and all of them, they unite, and finally this would be called as the apex. And it is not a big rocket science to say that apex would be pierced by urethra, true? And the urethra, which is before prostate, we call it pre-prostatic. After prostate, that is post-prostatic urethra. Now see, the apex, right, the lowest portion, which we said that that's where it would be pierced by the urethra. So this apex is important because that would be like a junction. This is the point from where names would change. So it is at that point, it is the prostatic urethra. And from this point onwards, so this would be the apex, right? That level is apex. And from there onwards, it would be called as the membranous urethra, right? It is the same thing, but the name changes, right? Because now prostate tells bye-bye to urethra, and there he is on his journey by his own. On the top, when the bladder is there, base, that is what is called as the base. And yes, we call that thing as the neck of bladder, right? Neck of bladder. Because bladder was like this, right? So we say that this is the neck of the bladder, neck, right? And that's how the prostate is arranged, correct? Plus, there would be circular groove. This is what we really would like to know. There would be the circular groove. And why that circular groove should be there? Because that's where there would be, this would be the home, right? That's how we used to make homes, right? Vesicle and prostatic plexus. Vesicle and prostatic plexus, they will be staying over here, right? So that's the base. Regarding the surfaces, right? Anterior surface, very easy. What anterior surface, where, what it would be doing, right? Anterior surface, right? So above was bladder and now it is coming below, to dead straight away, right? There would be that pubic symphysis, right? A wall, because it is the bladder who was becoming bigger, so going above the pubic symphysis, and when it is empty, so then it was dipping behind the pubic symphysis. But that pubic symphysis is big, so obviously in front of the head of prostate, right, there would be pubic symphysis. But this prostate is quite friendly, right? So prostate is over here, right? Pubic symphysis is over here. So he tells hello to that pubic symphysis. And there comes pubo-prostatic ligament, right? And this is like a very good friendship. So it is a good support, a very good support, right? Regarding the posterior surface, and you know that rectovesical pouch, and that fascia is called as the fascia of Denon-Villiers, right? Quite a stylish name, Denon-Villiers. And that's where on this, right, the posterior surface, from where the ejaculatory ducts would be entering, correct? Because they enter from the backside, so that would be the entry of right and left ejaculatory duct. That's what they do, right? Now this posterior surface, see, it is quite near to rectum, right? Actually, it is just 4 centimeters from anus, just 4 centimeter. So that's why in per rectal examination, right? In per rectal examination, this is quite important for the digital palpation, and we'll discuss it just within few minutes, that it is this area which is very susceptible for carcinoma. So that is when it is susceptible to carcinoma, right? See a prostate. So that's where the consistency of the prostate would change. That is evaluated with the help of digital palpation by per rectal examination. No doubt ultrasound, CT, they are there, but this is if someone wants to go for, say, clinical examination. Now to understand, say, prostate is as such pretty interesting, right? So much work is done on it. One, what is called as it is necessary to divide the prostate into zones, right? Now these zones, they are slightly confusing. As such, not at all. Once you understand, you'll find that they are important from the clinical point of view. Actually, histologically, or if you say anatomically, you will try, okay, are they lobes? No, they look like the just one structure, but they are divided with specific area. It is exactly like that if there is one, say, a housing society, and then they just divide it into like this, that this is block 1, block 2, block 3, 4, 5, 6. That's how, right? But as such, though, it is a complete land, right? So same thing happens over here. The zones they are divided into, right? First we'll just write down, just first we'll just understand, and then actually we'll see it in figure that how exactly are they, say, because it will shake our concepts a bit, right? Peripheral, our normal vision is peripheral, means which is surrounding, all right, right? It would be contributing 70% of that entire prostate glandular tissue, right? 70% of the glandular tissue. Central, it is about 25% of the entire glandular tissue. Something this makes sense. This is periurethral. Okay, periurethral, that means something which is surrounding the urethra. Yeah, so that is constituting about 5%. Okay, how are they important? This is where the carcinoma would be occurring, the most prone area for carcinoma, situated posteriorly. But we just said peripherally. Yeah, but hang on, right? This is situated posteriorly. Periurethral, periurethral, right? That is where the BEP, that is benign enlargement of prostate. This is also called as benign prostatic hyperplasia. Hyperplasia. That's what occurs in periurethral. Interestingly, the central one, right? This is not involved much in any disease. So he is quite happy, right? Not involved much. Okay. Now, how are they really arranged? To see this thing, we just revise a small concept, what we were talking about, that the sphincters, right? Those sphincters. There were two sphincters, proximal and distal, right? Urethral sphincters. And it was this proximal urethral sphincter was not present in female, right? That's why it was only the distal urethral sphincter. And we talked in detail about distal urethral sphincter, how those three bands, they really work, and why those, say, pubococcygeus muscles, they are so important, right? Proximal urethral sphincter, we just talked about that it would be telling no entry for all those sperms, right? So what it really does, technically it is speaking, it prevents retrograde ejaculation in bladder. Because the process itself, that ejaculation process, that is very enthusiastic, right? It comes with a pressure. So chances are very high that when the things are getting fired into such a small space, so all the way those sperms, right? Some sperms, they might start traveling up. So that is what is prevented by proximal urethral sphincter. Proximal urethral sphincter can also call that as pre-prostatic, correct? Pre-prostatic. Regarding the distal urethral sphincter, that is the voluntary control, right? That is the voluntary control. So let the good place, comfortable place come, and that's when it would be opened, right? So that would be at a junction of, when we say distal urethral sphincter, so this would be at a junction of prostatic and the membranous urethra. This means this will be present at the apex, right? Just we talked about that this would be the apex. So that's the location, that's the exact location where this thing would be called as the prostatic urethra. Further, it would be called as the membranous urethra. So that would be the junction of prostatic and membranous urethra. Right, this would be the prostatic urethra, this would be the membranous urethra, and that's what we are talking about. Okay, now comes the zones. We talked about those three zones, right? So let's see where they are into. So here is the central zone, right? That's the peripheral zone. Okay, it doesn't look like periphery, but yeah, peripheral zone. And then where is the third one? This third one, periurethral zone, this is another name, that is the transitional zone. So to clarify, we'll just write it periurethral zone. Okay. Now see this, just orient yourself properly that this is anterior side, this is anterior, this one is posterior. Right? So many things to learn in this figure. First thing first, and that is, what is this periurethral zone or the transitional zone? The name is telling periurethral, right? Surrounding the urethra. All right. So that's what it is, right? Surrounding the urethra. So that is periurethral. So this one, this is periurethral, right? So that is periurethral. It is also called as the transitional zone. This would be the most central part. True? Most central part. Perfect. Okay. There comes the central zone. Now the central zone is, right? This central zone, if you figure out where is it located, it is just for the name, it is central. Otherwise, what would be its location? As we said, this is anterior and this is posterior. So this central zone is posterior to urethra. Perfect. And above ejaculatory duct. And above ejaculatory duct. So this is what we are talking about. That is central zone. And this is the area which is common for carcinoma. And this is the area which becomes hard and which is palpated in digital palpation per rectal examination. Right? So that is central. Ejaculatory duct is fine. Whatever is left out is peripheral zone. Right? This is peripheral zone. Now, one other aspect to be seen is this anterior fibromuscular septum or the stroma. Anterior fibromuscular stroma. Prostate is made up of elastic fibers, smooth muscles, right? And we'll see it in more detail. And in fact, there are specific nerve supplies for these muscles, these smooth muscles, because it is not so that only one nerve is handling. It is the sympathetic operation, parasympathetic operation. One would be telling that, okay, erection. Second one will say, okay, let's start for the ejaculation. It is all the joint effort. Finally, it results into that complete process. So over here, it is this anterior fibromuscular stroma, right? That is getting a good support from above and from below. That's right. It is getting this anterior fibromuscular stroma is getting support from both the sides. From above is who? Above is bladder, right? In bladder, those musculature that was detrusor, right? So those detrusor muscles, they will come for the support. So detrusor muscles from above, they support this anterior fibromuscular stroma. As it goes down over here, there is what? There these muscles, that is distal sphincter, right? So this distal sphincter, it supports from below. So that's how from above and below the entire prostate is properly, say, placed, connected. Now, this new name, we haven't talked about this new name, verumontanum. To make things a bit more complex, there is another name, right? Is also known as seminal colliculum, right? Or seminal colliculus. What exactly it is? Not a very big thing. That's just a place where ejaculatory duct and prostatic duct, they open. Bus. That's it. And obviously it has to be in the posterior wall of urethra, right? Because they both land onto that urethra from the posterior wall. So that's how these things are arranged. Okay, this is regarding anatomical lobes, right? This is about lobes. See, truly speaking, these lobes, like previously there was like anterior, posterior, median and two lateral. Now they have made it simple. Anterior lobe, posterior lobe and median lobe. That's it. Baat khatam. Right? So in olden days, it was anterior, posterior, median plus two lateral. But they must have thought that course curriculum of medicine is very more, is so much. So now it is simply divided into anterior, posterior and median, right? So bit of relief. Things to see is all so easy. See anterior lobe, right? Then from the posterior aspect, see here is the ejaculatory duct, right? It enters. That's the ductus deferens, right? That's the seminal vesicle and joint operation, ejaculatory duct, and it opens. And yes, in this figure now we can say that this would be the path of that catheter, right? So this ejaculatory duct would be very scaringly watching the catheter passing, right? So that's the prostatic urethra regarding this posterior part. This is the posterior lobe. That's the anterior lobe. And this above one is the median lobe. And see, these are openings of prostatic duct, right? This lateral lobe nowadays it is part of that anterior only, anterior and posterior, right? It is divided in like that. So external urethral sphincter, right? And this is urethral crest, and these are the openings. This is the opening of ejaculatory duct. That's the cross section where it shows that how the prostatic urethra, right, that is arranged. To make it bit more easy, and this is how we need to know about the coverings. This is bit important, yeah. Coverings. Coverings of prostate. And once again, there are true and false, right? See, they are so fond of true capsule, false capsule, right? True pelvis, false pelvis. So let's start with true first, right? True is what is inside, and it is nothing but the peripheral part of the gland itself is condensation, right? So it is condense. So there is condensation of gland itself, the peripheral part, right? Peripheral part of gland. So that is condensed. Now this is fibromuscular. As it is important, we'll write it in capitals that this is fibromuscular. And this is more important because it would be continuous. It would be continuous with the stroma of gland. So the gland is there, the outer part it becomes condensed, and that is what leads to true capsule. Well, it has to be true, right? Because it is part of the gland itself. So this is, and it has to be continuous with stroma or the material of the gland. So that's fine. What about this false capsule? False capsule is just the pelvic fascia, right? Nothing more. So this is like external capsule. It is just the endopelvic fascia, right? Outer fascia. Just the endopelvic fascia. And this fascia, this is where that anteriorly, when this fascia was saying hello to pubis, so anteriorly it was leading to formation of puboprostatic ligament, right? Posteriorly, there was fascia. So that was fascia of that fancy name, Denon-Villiers, right? I'm just writing D. Okay. Denon-Villiers. Or the rectovesical fascia. True. Rectovesical. Rectovesical fascia. So that's what fascia is. And this fascia, right? And this fascia, this puboprostatic ligament, it is like, say, medial and the lateral, right? It is medial and the lateral. So from both the sides and medially also. So that's how it is. And they provide good support, right? They provide good support. Prostatic urethra, yes, we know about it. Things to know in this case is that these venous plexus, right? We are about to touch these venous plexus. These are the venous plexus which will be sitting between these two, between true and false, right? Venous plexuses, they will be sitting in between them. So for the blood supply, it is just internal iliac artery. Internal iliac has got anterior division, and then all these vessels, they are branches of anterior division of internal iliac. And how it does? As we said that there is vesicle, so over here it is inferior vesicle, right? Artery. So that comes. Then rectum would say that, well, middle rectal, so have one branch from me also. And then the big boss of pelvic region is internal pudendal, so we can't avoid her, right? So that is internal pudendal artery. All of them, what they do, they form outer and inner plexus, right? Because these structures are important. It is necessary to actually penetrate into the deepest tissues and to supply everything properly. So that's why plexus is. So there is outer plexus and there is inner plexus. And it is quite easy to understand. When it is outer plexus, that means it is for capsule, right? So it will just go underneath the capsule, and it is what is called as, also called as, subcapsular plexus. Fair enough. And one who is, say, inner will happily go till periurethral area. So it is periurethral or the central plexus, right? Or the central plexus. Makes sense, right? And that's how they are supplied. Say regarding the veins, same idea. They do exactly the same thing. All those veins, right, from the this gland, right, all those veins, they unite and they form plexus. Where would this plexus be formed? You are right, at the base, right? We talked about that they will be forming the base, forming the plexus at the base. And that plexus, then that internal pudendal vein, right, that also joins, and both of them happily go for internal iliac vein. Done, right? But there is a small bad part about it. A small bad part. Everything looks so good, but then comes that these plexuses, they have got habit to talk to even those vertebral plexus. We'll be talking about vertebral plexus. So these plexuses, they talk to vertebral plexus, right? So friendly are they that there is no barrier between them. That means there are no valves, right? Very friendly. But the trouble is when there is carcinoma of prostate, so at that time that travels to vertebral plexus. And from vertebral plexus, things go all the way to vertebral column and even into the skull. Right? The idea is because there are no valves. Right? You got it. There are no valves. So that's how things they really go. Now regarding lymphatic drainage, it is easy, very easy, because the most interesting part coming up is the nerve supply, right? Regarding lymphatic drainage, simple as that. Mainly, it would be going towards internal iliac, right? Everywhere, internal iliac nodes. And obviously, we are talking about the pelvis, so there would be some sacral nodes, right? They will be playing major role. Partially only, it would be this external iliac. Now let's talk about nerve supply. Now at times the nerve supply becomes pretty confusing, right? It is bit confusing. So I'm giving you a very simple diagram. In a way, and we'll keep on making it rich day after tomorrow. Right? One thing is clear, that this is prostate. And to supply prostate, we need to create a plexus. So let's give it a name, prostatic plexus, right? How scientific, right? Prostatic plexus. This prostatic plexus would be fed by inferior hypogastric plexus. Now, this inferior hypogastric plexus has tried to impress himself in so many organs, right? But the reason is, it is this inferior hypogastric plexus which would be supplying all these organs, but it is actually the continuation of superior hypogastric plexus. So that means there would be one more plexus. So it means day after tomorrow, we need to see that how the superior hypogastric plexus is formed. Yes, we would see that. But right now we'll think it like this, that it is not giving all the fibers with reference to prostate. With reference to prostate, it is giving only few fibers, right? We'll focus on that. Day after tomorrow, we'll be discussing all the fibers. So this superior hypogastric plexus will give, let's change color, sympathetic fibers, right? These sympathetic fibers, they are, now understand, they are motor to smooth muscles of prostate, right? They are motor to smooth muscles of prostate. Now these are smooth muscles because the way when the pizza is eaten, we don't have to tell the stomach that okay, stomach start digestion, right? Exactly during those happy moments, we don't have to tell the prostate that okay, your work is to be started now. So that's why this is sympathetic fibers. They are motor to smooth muscles of prostate. They will be going via inferior hypogastric into the prostatic plexus, into the prostate, and then they will be telling those smooth muscles that okay, contract, right? In simple words, ejaculation. So when those smooth muscles of prostate contract, so that leads to generation of that force, right, which will be putting large amount of fluid into the urethra and the process starts. But well, this much is not sufficient. This inferior hypogastric plexus, it is also getting supply from pelvic splanchnic nerves. So what these pelvic splanchnic nerves are doing, they will be giving the parasympathetic supply. Right? They will be giving parasympathetic supply. And pelvic splanchnic S2, S3, S4. Right? Now what they will do, this superior hypogastric plexus, he said, okay, motor to smooth muscles, yes, smooth muscles contract. But well, it's like that if the gun is to be fired, gun is to be loaded. That's the function of parasympathetic. These parasympathetic will say that okay, all those acini, right, those who are producing prostatic fluid, right, they are parasympathetic are responsible for secretomotor to those acini. So he'll say that okay, all the acini, right, load the fluid and then the sympathetic would fire it, right? So that's why this parasympathetic, they are for say erection, and they are secretomotor, right? They are secretomotor to acini. Now what are these acini? Acini are nothing but we'll see the histology, right? These are like basement membrane, and then there are, say, columnar, right? Columnar cells, right? And they secrete into the duct. All those ducts, they finally meet and they lead to formation of prostatic duct, and that is what it opens. So it means that those parasympathetics, they act over here on these acini, and this sympathetic, because these acini surrounding them, there are smooth muscles, right? So those smooth muscles, they will contract, so that collectively the entire fluid is pushed into the posterior wall, that is into the posterior wall of urethra, right? So that's the innervation of prostate, right? Now see, as we were talking about, so let's talk a bit about histology, right? It will make things crystal clear. Nothing very hi-fi, very simple. The entire area, right? This is loaded with stroma. So what stroma is? Stroma is nothing but, it is like an environment, right? Which is fibromuscular. Fibromuscular. When it is fibromuscular, that means there has to be two things, few fibers and few muscles. That's right. So it has got smooth muscles, right? And we just talked about why smooth muscles, because we don't have to tell prostate, okay, yes, man, that's the time, right? And then there are elastic fibers. These are the elastic fibers. So that is for its consistency. In between, there are islands, right? There are islands. These islands, they are nothing but, these are the actual glands, right? These are the actual glands, the prostatic glands. So these glands, or the acini, right, they will be producing the seminal fluid, right? And for production of it, one very important substance, that is 5 alpha DHT, very vital, right? DHT is dihydrotestosterone, right? Dihydrotestosterone. Now let's see these acini in bit more detail. And by the way, so this prostatic fluid, right? When we talk about this prostatic fluid, it is, apart from that, yes, it is important fluid, that secretion, etc., right? Two important things. It has got this, that's okay. It has got, say, citric acid. It has got that fibrinolysin. But there are two things. One is PAP. This PAP is prostatic acid phosphatase, right? Prostatic acid phosphatase is, that means this is an enzyme, right? And then there is PSA, right? This is prostate specific, and you must have guessed, antigen. Now both of them, they are normally, they are released in very small quantity into the bloodstream, right? Very small quantity in bloodstream. So this gives us the idea that in which condition they will be increasing. Well, that's why they are also called as the tumor markers, because they will be increasing into their values whenever there is something wrong with the prostatic tissue. Now, see what can go wrong. In medicine, to remember the etiology, we always follow congenital, traumatic, inflammatory, neoplastic, and miscellaneous. Right? This would be like a mantra. Congenital, no. Traumatic, no. Miscellaneous, no. Inflammatory, yes. Prostatitis, yes, it would be increased. Neoplastic and miscellaneous. Neoplastic, it can be divided into benign and malignant, right? Benign and malignant. Benigns which are well encapsulated, right? They won't spread. Malignant, something which spreads easily. There is no very or bad or very ill-defined capsule. So benign, yes, it is benign enlargement of prostate or the benign prostatic hyperplasia, right? So that is benign. Malignant, that is carcinoma. Yes, in these cases it would be elevated, right? So in case of inflammation, that is prostatitis, it will increase. And in case of neoplasm, whether benign or malignant, right? Benign or malignant, yes, it would increase. These are tumor markers. So let's say you have done prostatectomy. Still, you can keep on assessing the level of PSA and PAP. That is pre-op, you did it, and you can do it even post-op to figure out the presence of any malignancies at other locations, right? Whether the lymph nodes have been involved and still they are there. So that is where these tumor markers, they will be helping you. Okay, we were talking about acini, right? Let's see the acini, that what exactly are they. All the structures, they require a proper place to sit, right? All the cells, and that is what is called as the basement membrane, right? That is what is called as the basement membrane. On basement membrane, there are few specific cells. They are like stem cells. So collectively, both of them, that's what is called as the basal area, right? That is the basal area or the basal layer. On top of that, we change the color. We do have those gorgeous, big, and these are all simple columnar, right? These are simple columnar epithelium, right? But sometimes, right, they try to play some mischief. What I'm drawing is, sometimes they try to behave, though they are simple columnar epithelium. Simple columnar means one layer, right? How do we see this layer? With the help of those nucleus, right? All those nuclei, they are arranged in one layer. Yes, so it is one layer, right? But sometimes they they are arranged in such a way that it looks like as if they are arranged in multiple layer, but actually just one layer. It is the nuclei which looks like as if they are in different layers. So that's where they are called as the pseudo stratified. Stratified means layers, right? But it is pseudo, actually not nakli, right? So it is the pseudo stratified columnar epithelium, right? So this would be the characteristic of them. Now these cells, right? These cells, they keep on secreting, everything is fine. But say with age, as age increases, right? Now this is a completely normal phenomena. There would be accumulation of thick fluid. Accumulation of thick fluid, thick secretion, and that will lead to formation of some hyaline spherical masses, right? There would be, so they will keep on collecting, right? They will keep on collecting, and there would be some collection, right? And it will keep on increasing. So that is what is called as the hyaline spherical mass, right? Because it increases bigger and bigger. And that's what is called as the corpora, right? And this is amylacia, corpora amylacia. And it can occur that this thing might calcify. And when you are doing USG ultrasonography, sometimes you see the calcification that could be because of this. This is a completely normal finding, right? So this is a normal finding. But just to keep in mind that when you're doing ultrasound, right, at times if you see any of those small calcifications, right, nothing to worry about. They are the normal corpora amylacia. Just the recap, it's a sort of recap. See, this is prostatic urethra. That's the landmark or the hallmark of this prostate. These are the submucous glands in inner zone. That's fine. These are the large branching glands into the outer zone. And yes, all these outer or inner zone, they are ill-defined capsule, right? And then there are the mucosal glands for the secretion. Just to say this is right. These are this would be the site of benign prostatic hyperplasia, right? And this outer zone, that is the site of carcinoma. Okay, coming to the final part now. Some age related changes. See, at birth, the size is small, right? It's pretty small. And in first 6 weeks, it starts increasing, right? Because of the maternal hormones, right? It starts increasing because of maternal hormones. But that's it. Then it stops. All the way up to 9 to 10 years, right, there is no change. From 9 to 14, it starts increasing, right? Because now the duct system is developing. Duct systems, they develop. So as we discussed, that all those acini, right, they finally lead to formation of that duct. That duct system develops, and that's the reason that size now increases. Now, when the size increases, the size becomes double. It becomes double the size, and this is a very rapid process. It occurs very fast, right? Very truly, it is because of the male hormones, right? It is because of the male hormones. By 20 to 30 years, right, there is marked proliferation of all those glandular elements and everything. From 30 to 45 years, the size remains same. But that multiplication, that proliferation, that stops, right? That epithelial unfolding, right? Epithelia, they are there, but then those epithelial infoldings, they disappear. They don't appear now. And later, it may lead to decrease in size. Then the benign enlargement of prostate or benign prostatic hyperplasia, right? All those things, they can occur. But this is how things really go. Now, when we talk about, say, BEP, benign enlargement of prostate or benign prostatic hyperplasia, one thing is commonest is what is called as the urinary retention, right? Why there should be urinary retention? Because, say, now we can very well say that this BEP, it occurs into the inner zone, that is the periurethral zone. So when the periurethra, right, this is the urethra, the prostate, which is the prostatic tissue, which is over here, right, when it is enlarged, it would be actually, say, applying a pressure onto the caliber of that urethra, right? So this is what would be acting like a wall mechanism, and it will lead to urinary retention. The stream, urinary stream, right, it decreases, right? So person would be requiring more time. This is one more reason that why all the males, they should go for that Kegel exercise or pelvic floor exercise, because one of the another effect is that it keeps the health of the prostate very well, right? That's the reason all those exercises, they are to be done at this point when you are young, right? Solution, prostatectomy, right? Prostatectomy. That means removal of the prostate. It could be, there are so many methods. One is like transvesicle, right? Name itself is like, say, via bladder. Or it could be retropubic. These are all various approaches. This is what we shall be discussing when we'll be going for learning the surgery. Or it could be perineal, or it could be TUR. This is what is called as the transurethral resection. That is TUR. That is the transurethral resection. But the trouble is, this TUR, when it is done, when actually the probe passes, the chances of damage to urethral sphincter, that is very high, right? So it may lead to some more complications. So that's like, just you know it now so well, that that's the prostatic carcinoma and the benign prostatic enlargement or the benign prostate hyperplasia, that is into this central area, because that's where it would enlarge and will lead to this compression, right? Rest is all easy. Okay, when we talk about the CA prostate, right, when we talk about the carcinoma of prostate, it is into the peripheral zone, right? Into the peripheral zone. For the inflammation, what's called as the prostatitis, right? Prostatitis. This was second condition. First was BP. This is third one, that is prostatitis. Any of the inflammation, it is to be divided into two parts, that is acute and chronic. Chronic, that means it is long standing, right? And when it is acute, acute means it will come from somewhere, right? And the commonest could be urethra. So it could be urethritis complication, right? Because that is the commonest thing. Chronic, it has to be secondary to something which is developing since long. Say, for example, tuberculosis infection, right? It could be tuberculosis infection. It could be from epididymis, seminal vesicle, bladder, all those nearby structure. Anyone can get this, right? So it could be from bladder, it could be from, say, seminal vesicle, right, etc. So that's the whole idea, that from where the infection is coming. It could be from anything. Chronic means just it is the long standing, right? It is long standing infection. That's where this is what is called as the PR, or the per rectal examination. And from anus, this distance, right, that distance is just 4 centimeter, right? It is just 4 centimeters, 4 centimeters. And normally one digit, right? One digit, this one, it is about 2.5 centimeters. So it is just by application of a slight pressure, and instantly it should be very easy to palpate the posterior part of the prostate gland, right? What we need to do in BPH? Well, see, when the patient is having benign prostatic hyperplasia, as such, nothing happens, right? It is not so that it would be converted into carcinoma and this, that. No, nothing. Either it can be, say, surgically removed. Now, it totally depends upon the person. It totally depends upon the person. Can be removed surgically, right? Even a partial prostatectomy can be done, or say, many people, they live with it, because the urinary incontinence, that stream would be slowed down. So that's why it is said that if they relax, right, if they relax, they need some time for maturation. It won't be as fast as they were when young, right? So that's why there are so many things how this thing can be handled. Now we talk about that vertebral plexus, that vertebral plexus which I was talking about. That these vertebral plexus, why they are important? Because carcinoma of prostate, it can easily spread to vertebral column and lungs, right? That's the importance. It is also called as the Batson's plexus. Batson's plexus. An importance that see a prostate, right? It can send all those secondaries to skull, vertebral column, etc. Right? So why should it really happen? See, in this, we'll look for 3 areas first. One, this epidural plexus, right? So this is the spinal cord, right? The dura mater outermost, dura mater, arachnoid mater, and the pia mater. It is the dura mater and outside the dura mater. So every structure, right? Every structure is inside. But outside the dura mater, this is epidural plexus. This is epidural plexus. So this is outside. So let's mark this thing as 1, right? So that is first thing. Second, see, there is a plexus which is within the vertebral body. Now these are all venous plexuses, and this is into the vertebral body. So that's what we are talking about, right? The first one was this. So let's mark this thing as 2. So that is the venous plexus within the vertebral body. Then the third one, see, which is onto the anterior part of, again, the venous plexus. So that's the third. That's the third, right? And still, these 3 things, they all are communicating with each other. See, they are communicating with each other. So it means anything, if it enters, right, all these vertebral channels, right, these posterior part, there is a posterior part, that's the fourth part, right? So that's where it is connected. So everything is connected, and this thing can actually go up, can go down, right? So due to this vertebral plexus, things can really go worse. See, because they all are valveless. So this vertebral, say, plexus, right? If it goes up, it may lead to straight away intracranial venous sinuses. They are affected. It can communicate with them, right? Goes down. So in that case, there are pelvic veins. And how dangerous would it be? Because it would be in communication with portal veins. It would be in communication with superior vena cava, inferior vena cava. So that means everyone becomes connected, right? So that's the reason that it can prove so dangerous, because there are no valves. And as there are no valves, any increase in intrathoracic or intra-abdominal pressure, right? Any of the increase in intrathoracic or say for example, coughing, that will raise intrathoracic pressure. Any of the strain, right? Any of the strain that would lead to intra-abdominal pressure, all that would lead to that blood flow would be diverted, right? Blood flow direction changes because of this strain momentarily, but that direction changes. So it may lead above or below, and that one would be sufficient to spread. That's why this vertebral system, the vertebral venous system, that is so dangerous, that any of the pelvic, any of the abdominal pathologies, right, any of the thoracic, breast cancer, right, all those things, they can spread so fast, right? Because once the venous system is involved, so then you'll find that CA breast going into lungs, liver, spleen, kidney, where not, right? They go into the skull, they go into the brain, right? Everywhere it can really spread. So that's what it is seen. And when you really do say CT scan, so you'll see those osteolytic lesion, right? Those lytic lesions, as if into the entire skull there will be some areas with low opacity, right? Low opacity areas, they will be seen. They are what is called as the osteons, right? They are called as osteons. So that is what you really see. So that's it for today. Thank you so much. And tomorrow we meet at 7 o'clock, right? I just save this and I'll put it into our folder. Thank you and bye bye and good night.